In this presentation, I'll be talking about a basic cervical spine CT search pattern. So here's an overview of the steps I go through in a basic cervical spine CT search pattern. One of the first things I always do if there is instrumentation, you just look at the instrumentation, describe the instrumentation. If there are any complications, you describe it, and then talk about the rest of the spine. I'm not going to focus too much on that just because it will disrupt the flow of the basic search pattern, but that's sort of how you would start like a report. For instance, you would say there's a C5, C7 anterior cervical discectomy instrumented fixation. Instrumentation is intact. There's no lucency surrounding the screw, so, and then you move on to all the remaining steps of the search pattern. Then I start with alignment. Then I'll look at the craniocervical junction, the prevertebral soft tissues, any fractures that might be present. Then you look for incidentals, look at any visible parts of the brain, the soft tissues, and the long apices. And finally, I spend time and talk about the degenerative changes. So first thing I look at is alignment of the cervical spine. Normal cervical spine alignment in the sagittal plane should have a little bit of a lordosis, so a curve this way. Here, there's a little bit of a straightening of the cervical spine alignment, and that's perfectly normal, especially in the setting of trauma. They have a collar on, their neck's going to be straight. What you look for in the sagittal plane for alignment is listhesis, meaning one vertebral body being either anterior or posterior compared to the vertebral body below it. The way you describe listhesis is always the vertebral body above with respect to the one below. So you will say there's anterior listhesis of C2 on C3 or retrolisthesis of C2 on C3. As far as grading, there's a numeric grading system for anterolisthesis in the lumbar spine. I don't use it for the cervical spine just because it was used it's designed for the lumbar spine, and sort of at my training at least, we sort of never talked about it in the cervical spine, just used it for lumbar spine. That being said, other people use it in the cervical spine, and it's probably just fine. Then, whenever you see listhesis, you always want to look at the facets and make sure the listhesis isn't due to facet injury or a jumped facet or something like that. So you want to make sure that facets on both sides, here I'm only looking at one side, but you'd go on both sides and make sure that the facets are normally articulated. A lot of times the listhesis is due to facet osteoarthritis. So, when you have listhesis, you want to look at the facets and also make sure that you can account for the listhesis by the way of seeing some facet osteoarthritis. Then you look at the coronal plane for scoliosis. So although you can sort of get a hint of whether there's scoliosis or not in the sagittal plane as well, if you see all vertebral bodies in the same plane and in the same shape, that just means there's no scoliosis. But if you see the top vertebra on the plane and then the middle vertebra go out of plane and then all of a sudden the bottom ones come back, there's gotta be scoliosis. If we do coronal MPRs here, you can see, you don't see all of them in the same plane just because this was a little bit slanted, but there's not much scoliosis here. One thing to note is for alignment in CTs, there's not a lot of emphasis placed when you get these CTs on patient positioning, and therefore small variation in alignment from one study to the next are almost meaningless. This is in contrast to when you get radiographs, when this positioning is quite standardized. You have standing radiographs, you would have supine radiographs, you would have bending radiographs, etc. So radiographs following alignment makes sense. On CT, following alignment doesn't make as much sense as on radiographs. Then I look specifically at the craniocervical junction. That's where the occipital condyles articulate with the lateral masses of C1. And I look at it thoroughly on all planes and on thin sections if possible, just because any fracture here can actually be very important and kind of unstable and sort of potentially dangerous to the patient, especially like small chip fractures or avulsion fractures here at the tip of the occipital condyles. That's where the alar ligaments attach, and those can be actually quite unstable fractures. So any fracture here is very important, and you got to really interrogate your occipital condyles and the craniocervical junction alignment. Make sure there's no widening, no asymmetry, etc., and then obviously look at it in all planes. So you look at it then on the axial, make sure there's no chip fractures here coming from the tips of these occipital condyles. And then finally on the sagittals as well, going on each side and making sure that they're nicely articulating, not anterior or posterior, and there's no widening of the distance between the occipital condyle and the lateral mass of C1. And of course, you do it on both sides. Then I look at the prevertebral soft tissues, mainly look for any swelling, and the sagittal plane is really good for that because you can see nice thin soft tissues here, sort of at this level where your upper esophageal sphincter would be, and the esophagus starts. You're going to have some more thickening of the prevertebral soft tissues, and that's perfectly normal. But this is what normal prevertebral soft tissues are supposed to look like. So you kind of scroll a little bit to either side, make sure there's no soft tissue swelling, and then just follow that up with a quick look on your axials and make sure again there's no soft tissue swelling, edema in your prevertebral space, or lifting of this or lifting of this retropharyngeal fat to suggest that there's some prevertebral hematoma or edema, or something that might imply a ligamentous injury or a subtle fracture that you might otherwise miss. A lot of times subtle fractures, a big clue to them is the prevertebral swelling that you can detect. So never skip out on assessing the prevertebral soft tissues before you start looking for fractures. Just because you see prevertebral soft tissue somewhere, you really got to interrogate that region when you're looking for fractures. Next, I look for fractures, and as I'm scrolling through, also any sort of lytic or splastic lesions that might be around as I'm scrolling through. So first thing you do is you look for vertebral body heights, and you include the thoracic spine vertebra, and obviously that's done best on your sagittal plane. It's not uncommon for people to miss thoracic spine sort of simple compression fractures on these C-spine CTs. I think people just, it's a C-spine CT, so we would just look at the C1 through C7 and ignore or overlook those thoracic vertebra. Then I usually, while I'm still on the sagittal, I go to either side and look at the facets, make sure they're properly aligned, there's no fractures, including fracture of these tips of the articular processes, etc. Then while you're still on the, obviously you look at the other side as well, and then when you're done, you go back to the midline, and I look at the spinous processes, because fractures of the spinous processes are typically best seen on these sagittal views. Then I obviously go to the axials, and I sort of start at the top and sort of scroll down, and look for any fractures. If there are thick sections, I tend to sort of go on the thick sections and just very slowly scroll slice by slice, no fast scrolling, and just interrogate each slice all the way through the circle of every vertebral level, and make sure there's no fracture at any of either the body or the posterior elements. Whenever I go through a foramen transversarium, I tend to slow down and I make sure that there's no fractures going through that foramen transversarium, just because the vertebral arteries are there, and whenever you have a fracture to the foramen transversarium, that increases likelihood or possibility that the vertebral artery is injured, and then it might be worthwhile to recommend a CTA of the neck to make sure the vertebral artery is intact. Now, obviously, you go through all your cervical spine levels, but there are other bones that get included. You have some parts of the calvarium included. You usually get a little bit of the mastoids. This one you don't get so much, but the temporomandibular joints you get. So you make sure you got the temporomandibular joints. Make sure those are intact. Again, depends a lot at your institution and how much they reconstruct. And then on the bottom, again, depending on how much they reconstruct, you're going to see some ribs. You're going to see the clavicle, portions of the manubrium, and again, depending how far lateral they go, you'll see some parts of the scapula even. So make sure to interrogate those bones as well, and see if there's any fractures. Next, you look for incidental findings, starting with the visible brain. So you put your brain windows on, you look at the visual portions of the brain, which are typically going to be your posterior fossa, as well as the bilateral middle cranial fossa. Just look for any hemorrhage, any mass effect, etc. A lot of times you already have a head CT as part of a cervical spine CT, so it's not necessary, but if the head CT has not been performed, definitely look for those areas. Then you put on soft tissue windows and then look at the soft tissues. Now this, what soft tissues you see is just going to be very dependent on how much they reconstruct for you. But really, you just got to go through a neck CT search pattern essentially, and I have a lecture on neck CT search pattern. Uh, More straightforwardly, I typically just make sure I look at the salivary glands or the parotid glands on either side. So parotid gland here on the left, parotid gland here on the right, the submandibular glands on either side here and there. Go down and look at the thyroid and make sure that's okay. Very common to find little thyroid nodules, etc. As I'm coming up, I look at the major lymph nodes, here, supraclavicular, cervical level 5, coming up, your jugular chain lymph nodes, make sure there's no lymphadenopathy, and then I come back down one more time while looking at the pharynx and larynx. So you start up here at sort of your nasopharynx, make sure there's no asymmetry or mass, come down your oropharynx, and then you come down. You're going to have your supraglottic larynx, your hypopharynx here. Make sure there's no asymmetry, no asymmetric effacement of any of those recesses, like your piriform sinuses or vallecula in the setting of the oropharynx. Here are the vallecula, here are the piriform sinuses. Then you look at the larynx, make sure again, no effacement, no mass, etc. And then finally, once you're all the way down, you put on your lung windows and just interrogate the lung apices. Make sure there's no nodules, masses, consolidations, pleural effusions, etc. Especially be on the lookout for pneumothoraces, something not uncommon that you'll see an unsuspected pneumothorax, or at least you'll be the first person to detect a pneumothorax, just because these are non-contrast images, and a lot of times they're done first before they do the contrast enhanced chest CT or something like that. Finally, I end with talking about degenerative findings. Now, if you're doing something for trauma, you don't spend a lot of times going level by level, describing degenerative changes at each level. But if the study is done for follow-up degenerative disease, obviously you go level by level. And at each level, typically beginning at C2, C3, you describe, every detail of the degenerative findings as we'll go over. First things first, though, usually talk about, sort of C1, C2 arthropathy, if there is any arthropathy, if there's any pannus formation posterior to the dens. Pannus is just some soft tissue that can happen posterior to the dens when there's arthropathy between C1 and the dens. The soft tissue can a lot of times be calcified, and if it's bad enough, it can actually compress the cord at the craniocervical junction. So if there's any pannus, I just say, oh, there's C1, C2 arthropathy with soft tissue or partially calcified pannus formation, but no craniocervical junction stenosis or something like that. At all the other levels, let me put the localizer on. So at all the other levels, you can talk about the discs and end plates. So the discs, obviously, you can see disc is a sort of soft tissue in attenuation here, contrasted with the fluid of CSF here and slightly higher density of the cord here. So this is the disc. If you have a bulge, that means just the disc is going beyond the confines of the vertebral body posterior edges. This little amount of it going beyond is not enough to call a bulge. And you can look on your axials and see how much further this disc goes. See, here's the disc right here. This is the soft tissue attenuation. This is bone. So this is disc. If there was a bulge, this disc would be further up, and it will be coming out from the confines of the vertebral bodies by greater than 90 degrees. That's what makes it a bulge. And bulges, mind you, can also be anterior or can be lateral or can be posterior. They're not always going to be posterior. It's just the thing that makes it a bulge as opposed to a herniation is that it's greater than 90 degrees of sort of the circumference. Now, if there's a outpouching of disc material, which again, disc is soft tissue attenuation, that's how you can tell there's disc material. If that outpouching is less than 90 degree in circumference, that's called a herniation. Now, herniations obviously are going to be further characterized into protrusions versus extrusions, but protrusions will be when the sort of widest part of the herniation is actually right at the margin of where the normal disc would be. That would be called a protrusion, meaning that the widest part is right at the beginning, versus extrusion, the widest part is not at the beginning. So that's what distinguishes the two. Sometimes it can be hard to tell, honestly, and so you can always just use the more non-specific term of herniation. Just say there's a herniation, etc. Herniations, you can kind of describe them as locations, like central. So it's right here would be central. You can have like subarticular herniations right here. You can have foraminal herniations in going into the neuroforamen or extraforaminal, which is outside the neuroforamen right here. And then you make a distinction and talk about any end plate osteophytes. And osteophytes, of course, would be bony outpouchings here from the edges of the vertebral end plates. And those can also cause degenerative changes. So when you're talking about discs and end plates, that's usually when I'm going level by level, that's what I first talk about. I talk about whether there's any disc bulge, any disc herniation, and how much osteophytes there are. Then I talk about facets and oncovertebral joints. So first, the facets, obviously nicely seen on sagittal plane. Here you can see what the facets look like in the sagittal plane, nicely articulated on each other. I talk about if there's any degenerative change, meaning that this sort of joint space starts to get narrow. You're going to have some osteophytes forming, potentially even a little bit of subchondral cysts or erosions forming, and then how much that osteophytosis is. Now, facet osteoarthritis typically doesn't cause a lot of neuroforaminal stenosis, at least in the cervical spine. In the cervical spine, what causes neuroforaminal stenosis, and this is the neuroforamen, that's where the nerve roots come out, is oncovertebral joint osteoarthritis. So the oncovertebral joints are obviously best seen on the coronal plane, and I'll go here. So oncovertebral joints are sort of these joints right here. They're sort of between the vertebral bodies here. These are the uncinate processes, these little processes that come up here, and they form a joint with the vertebral body and the end plate above. So here you can see them. This is the oncovertebral joint here. That's the oncovertebral joint on the other side right here. And then on the axial plane, you can see them, these little lines here. These like sort of anteroposterior going lines are the oncovertebral joints sort of between this part of the vertebral body below and the end plate of the vertebral body above. So anyways, there you have narrowing of these with there's osteophytosis, you have osteophytes forming around here, and then this part of the vertebral end plate typically would start to get hypertrophied in the setting of oncovertebral joint osteoarthritis, and those osteophytes go into the neuroforamen, and then they cause neuroforaminal stenosis. So typically, neuroforaminal stenosis in the cervical spine is going to be caused by these oncovertebral joint osteophytes. Sometimes the osteophytes also will encroach into the spinal canal and contribute to spinal canal stenosis as well. So once I'm done describing the discs, the end plate, the facets, and the oncovertebral joints, then I can start and actually give like a subjective estimate of how much spinal canal stenosis there is. There are some attempts at standardizing these things, but I think for the most part, majority of people sort of use a sort of very subjective scheme that they can be pretty consistent in to describe the degree of spinal canal stenosis. And as you can imagine, there's not a lot of consensus when you look at these things systematically about what one person says versus what some other person says. Sort of what I use for spinal canal stenosis, especially if I have a good quality image like this. Here you can see, you can tell the CSF separately from the cord. See, the cord here is this darker or brighter material versus CSF, which is pretty much darker. And then you can even tell the discs even brighter than both of them. So here you can see in this level, there's absolutely no CSF obliteration, so there's no stenosis. If there's just a little bit of CSF obliteration, but there's still like CSF on either side of the cord, I typically call that mild, as even if the CSF anteroposteriorly is obliterated, but there's still a good amount of CSF on either side, I call that mild stenosis. If the CSF is beginning to get obliterated even laterally, or if the CSF is obliterated anteroposteriorly and there's a little bit of cord deformity, like the shape of the cord is affected, I typically tend to call that moderate. And I typically reserve severe stenosis for when the CSF is completely obliterated, or if I can't see the CSF very well, which happens a lot in just a CT, just sort of go by gestalt. Do I feel like all the CSF at this level is obliterated or not? Now, some people actually do measurements of the canal diameter, or even, they measure the canal at centrally and sort of laterally, etc. I think that's excessive, but again, whatever is common practice at your institution, I typically just do a subjective as I described for the degree of spinal canal stenosis. Finally, you talk about the degree of a neuroforaminal stenosis. Now, in the cervical spine, if you want to accurately determine how much neuroforaminal stenosis there is, you have to make these oblique sagittal or oblique coronal MPRs that sort of go across the cross section of the neuroforamen, because as you can see, the neuroforamina in the cervical spine are actually slanted like this. They're not either sagittal or coronal. You can see here on the sagittal, if you look at this localizer line, this is not going through the cross section of the neuroforamen, and as you can see, the neuroforamen is never properly profiled on these sagittal planes. So what you really have to do is what you can do is make these oblique sagittal reconstruction that goes precisely through this neuroforamen like that, and then you got to follow it up with another oblique reconstruction through the neuroforamen right here. So I can show you how this would work on this PAX, for instance. Again, each PAX is going to be different. Here in this PAX, you first put your cursor on sort of the center of the neuroforamen here. This would be the fulcrum of when you're doing 3D MPRs. Remember on these PAXs you can do 3D MPRs. So then you do 3D MPRs here. You have to wait a second for it to go into 3D mode, and then you sort of turn it so that now you're going to be obliquing this reconstruction until it's sort of, yeah, now it's pretty good. I think now this, if you look at this yellow localizer line corresponding to this, it's now oblique so that it's going straight down, straight through the neuroforamen. And as you can see now, this neuroforamen is nicely, you're going through the cross section of the neuroforamen right here, very nicely, and you can see the whole cross section. Nothing's encroaching on it, no end plate osteophytes, no facet osteophytes. You can change your windows even, if you want, etc. There's nothing encroaching, and this neuroforamen perfectly normal in caliber. As you can imagine, this can be pretty cumbersome, especially if there's like superimposed scoliosis, or if they did a bad job of, your discs aren't really parallel. So you have to first align this to be parallel to your discs, and then then make sure this is sagittal to your the discs, and then oblique this one to go and be on the cross section of the neuroforamen. It can be pretty cumbersome. So most people just, again, get in the habit of looking at all slices of a neuroforamen. So you see this neuroforamen, this C2, C3 neuroforamen, for instance, starts all the way here, right? So you look at all the slices and you see how much sort of osteophytes encroach on that neuroforamen. And then in your mind, you keep track of, okay, how many slices were narrowed versus how many slices were patent. And then you kind of come up for yourself. If like half the slices were narrowed, that would be like mild or moderate. And if like almost all of them were narrowed as a result of osteophytes, that'll be severe, etc. So you just sort of, I think when you're starting out, it's good to do this exercise of making these sort of oblique MPRs and determining the true degree of neuroforaminal stenosis, and then going back on your axials and looking at what it looks on your axials, so that you can train your eye to sort of automatically translate what the actual images look like to what these proper oblique sagittal reconstructions look like. And that way, when you're actually reading these independently, you can do it quickly and you don't have to do these kinds of cumbersome oblique reconstructions.